Chapter 34 discusses acute kidney injury and chronic kidney disease. The first thing that you should understand are some of the important lab values that we use to monitor kidney function or to kind of diagnose or define different levels of kidney disease. So I'm going to ask that you kind of look up the normal ranges for these tests and really think about how they are affected in kidney disease. So some of the serum markers you see listed here, and then below that are some of the markers that we see in urine. So these again will all be really important. We'll talk about several of them today, but you should familiarize yourself with these. So with renal failure or kidney failure, the definition of this is any condition which the kidneys fail to remove metabolic end products from the blood and also to perform their important function of regulating fluid, electrolyte, and pH balance of those extracellular fluids. So remember, in fluid and electrolytes, many of the things that we talked about, all the fluids, all the water balance, all the electrolyte balance, and all the pH kind of buffering systems are largely driven by the kidneys. So when the kidneys fail, those systems don't work very well, right? Some major underlying causes, it can be renal disease itself, or there are many systemic diseases that can also lead to renal failure. And there are also some urological defects of sort of non-renal origin. You can see kind of the little picture here. This is something from acute kidney injury, but the reason I picked it out is that you see the kind of major things that the kidneys normally manage, which fluid, electrolyte, acid, base, and some of the things that we start to see building up in the serum when the kidneys don't work as well. Renal failure can either be abrupt, like we see in acute kidney injury, or it can have a slower insidious onset that we see in chronic. It can be reversible, which is the case often with acute kidney injury, or it can be caused by irreparable damage to the kidneys themselves, which we see in chronic kidney disease. So a little bit more about those two types of renal failure. Again, there's acute renal failure, which is abrupt in onset, but often because we know the cause of acute renal failure, if we reverse that cause, we can also reverse acute renal failure. So as long as we get those things reversed before we get significant renal damage, someone can go back to having normal kidney function. In chronic renal failure, the end result is really irreparable damage to the kidneys. It develops really slowly, usually over the course of a number of years. So usually we're working to kind of slow down the progression, but once that progression occurs, we can't really go backwards. So we're going to start with acute kidney injury. So again, this is a rapid decline in kidney function. It usually occurs over hours or days. It is a really common issue in critically ill patients. So we do see a fair amount of acute kidney injury in intensive care unit patients. And the development of AKI is really closely associated with increased risk of morbidity and mortality. So it's really something that we don't want to see happen in these critically ill patients. It really requires rapid correction of some of those life-threatening fluid and electrolyte disorders. As with all things, when things happen acutely, really quickly over time, it is harder for the body to really adapt to those fast and rapid changes. And so that's why AKA can be really dangerous from the standpoint of significant fluid and electrolyte challenges. Some AKI indicators, one big one is something called azotemia, and that's the buildup of these nitrogenous, nitrogen-based wastes, things like urea, nitrogen, uric acid. Creatinine is one of our major measurements of this in the serum itself. And we also see a decrease in what we call GFR or glomerular filtration rates. Acute kidney injury can be divided into kind of three categories based on its causes. They can be pre-renal, intra-renal, or post-renal causes. Our pre-renal causes are usually things that significantly reduce blood flow to the kidneys. And so we'll talk about all of these individually. Intrarenal or intrinsic are things that damage the structures within the kidneys itself. And post-renal causes are things that block the outflow of urine, causing this kind of retrograde pressure back into the kidneys itself that can lead to damage of kidney structures. So with acute kidney injury, as I mentioned, it happens a lot in critically ill patients, and it can lead to a lot of morbidity and mortality challenges. So we really have to think about who is at high risk for AKI and work to prevent this from happening to prevent that increased morbidity and mortality. So identifying people at risk is important because those mortality rates can be anywhere from 15 to 60%. Often that range is really based on the severity of the underlying illnesses other than kidney disease that person is dealing with. But assessment measures that we use to identify people at risk of AKI, anyone with pre-existing renal insufficiency, so if they came in with some abnormal kidney function to begin with, anyone with diabetes, anyone with vascular diseases, so if these are things like peripheral vascular disease or cerebral vascular disease, cardiovascular disease, anything that already is damaging blood vessels, we already may assume that we've got some maybe some blood flow abnormalities to the kidneys too, so they're at high risk. Anyone with heart failure, because they don't have as good of kind of cardiac output, so their blood flow is already potentially impaired to the kidney. Elderly folks are always at risk. They're one of our biggest populations of people who do end up developing acute kidney injury when they're seriously ill with other things. Anyone with, in the hospital with a critical care hospitalization, people with history of significant hypertension, or people with liver disease. Um, the other thing about anybody in this kind of risk category, they're also at much higher risk of developing AKI if they're given any drugs that might be nephrotoxic. So drugs like NSAIDs that alter any intrarenal hemodynamics. And again, older adults are susceptible to all forms of acute renal failure because they really have kind of lost this what we call renal reserve because of the overall effects of aging. So within AKI, there's kind of a standard course that our patients go through during the development of acute kidney injury. There's the onset phase, and this starts right at the time of whatever is causing that tubular injury to occur. And we'll talk about all those causes when we get into the different types, but that's when onset starts. The next phase is our oliguric or even anuric phase. Oliguria is low urine output, anuria is no urine output. So this phase is marked by a significant decrease in glomerular filtration rate, or GFR, an increase in nitrogenous waste, so that azotemia, and very low urine output. During the oliguric phase, fluid retention causes edema. It can cause things like water intoxication. It can cause pulmonary congestion, so we have a patient who is short of breath. If that period of oliguria persists or is prolonged, these patients typically develop hypertension that is very difficult to treat, um, and other signs of uremia. So things like neurological manifestations, so neuromuscular irritability like seizures, they can become very sleepy. They can even, if remaining untreated, slip into a coma or even die from these neuro kind of changes. Hyperkalemia usually develops. It's asymptomatic until those serum potassium levels climb to about 6 to 6.5. At that point, we usually see EKG changes. We see muscle weakness. So those are some of the kind of significant changes that happen in that oliguric phase. The next phase is the diuretic phase, and this is when the kidneys are really starting to heal. So our urine output may start to increase. We may see some improvement to some of our kidney markers. And then finally, the recovery phase, where our renal function improves and may even go back to baseline. So we'll start with some of the pre-renal causes of AKI. So again, pre-renal are anything that causes a marked decrease in renal blood flow. So here you can see the renal artery supplying blood to the kidney itself. If anything disrupts the normal flow of blood into the kidney, we can get a pre-renal AKI. Okay. So one major cause of prerenal AKIs are hypovolemia, anything that causes a significant drop in circulating volume throughout the vascular system. So some significant causes of hypovolemia may be things like massive hemorrhage, significant dehydration, any significant water loss to the GI tract, or any significant water loss that we see through the skin surfaces, especially in patients maybe with extensive burns. You guys will talk about burns. We'll talk about that a little later in the semester, and then you'll work with burns in your acute care course. But what you'll find out is one of the major treatments for burns is immediate and aggressive fluid replacement in those patients. Another cause might be something called decreased vascular filling. This is where we get such significant kind of hypotension and capillary kind of leaking that we get all this third spacing of fluid. And so now that fluid is not in the vasculature. And without good vascular tone, we get reduced blood flow to the kidneys. So things like anaphylactic or septic shock are two major causes of this decreased vascular filling. Other things, heart failure and cardiogenic shock, where we get this overall major pump failure. So if the heart itself is not functioning, we're not pushing enough blood forward to the kidneys to maintain their function. And the final thing is anything that causes decreased renal perfusion. So things like vasoactive mediators. So drugs that kind of clamp down or really constrict the vasculature can cause this. And then some diagnostic agents as well can cause severe kind of decreases in renal, overall renal perfusion. So then we'll talk about some intrinsic or what we call intrarenal causes of renal failure. So we often term this acute tubular necrosis. So this is injury to the tubular structures within the kidneys or within the nephrons themselves. Um, that's the most common cause of intrarenal AKI. Your tubular epithelial cells are particularly sensitive to things like ischemia, and they're also very vulnerable to toxins, really just because of the overall function of the kidneys themselves, right? They are there to filter things, and the um, kidney structures themselves are very much exposed to your blood supply. So they're very kind of exposed and vulnerable to the effects of toxins. Anything that causes like prolonged renal ischemia will start to damage the tubules themselves. Any exposure to nephrotoxic drugs like NSAIDs, any exposure to nephrotoxic metals or organic solvents, we can also get intratubular obstruction or blockage of the tubules themselves from things like hemoglobinuria, myoglobinuria, myeloma light chains, or uric acid casts. So these are things that may build up in the blood due to different causes. So something like myoglobinuria, for instance, is the result of severe muscle trauma. So if someone is extremely hyperthermic and they start to get a massive amount of breakdown of their muscles, that causes us to develop something called myoglobinuria. And those kind of breakdown products of that muscle start to make their way into the kidneys, and they start to obstruct and damage the nephrons themselves. So that's just kind of one example of what we mean by some of those things, like hemoglobinuria. That can happen after a blood transfusion where someone maybe has a hemolytic crisis, and all that massive breakdown when those blood cells kind of are destroyed, all of those byproducts make their way over to the kidney and can cause obstruction in those renal tubules themselves. Okay. The final cause, and this is really the least common cause of AKI, 10% of cases or less are usually caused by obstructive reasons. But these are anything that obstruct the outflow of urine from the kidneys themselves. So this is happening after the renal kind of filtration and creation of urine happens. And normally it would flow down through the ureters into the bladder and out through the urethra. But if something blocks that outward flow, it can lead to kidney damage. So this can happen from ureter obstruction. So here's your ureter right here. You have two of them. So usually for someone to have truly post-renal AKI, they would need both of those ureters to be obstructed, or they would need to be a person who maybe only has one functioning kidney. Otherwise, the other kidney would take over if it was just unilateral. But if something is caused by lateral obstruction, ureter obstruction can certainly cause um, post-renal AKI. So anything like renal calculi or strictures, this is kind of a stricture that you see up here, right in this ureteropelvic kind of junction, way up high. You can also get this from bladder obstruction. So within the bladder itself, if someone has maybe tumors, or if they have something called a neurogenic bladder, where there's either a neurological or a muscular reason why they can't empty their bladder, then that urine can start to back itself up. That can more easily cause post-renal failure than a ureter blockage, because now we've got backup into both kidneys. And the other cause might be urethral obstruction, so obstruction way down low in the urinary tract. So a common cause of this is BPH or prostatic hyperplasia. And again, this can cause backup all the way into both kidneys. Okay. So obstructions here cause this retrograde or backup pressure. And if that pressure persists, it starts to kind of press down and damage the nephrons within the kidney. And that's what leads to AKI in these cases. Treatment here is really, you have to relieve the obstruction. That's the best thing you can do to prevent any damage, and you want to do that before you have any nephron damage that's permanent. So the treatment of AKI, the big thing that I'm going to say again here is you really need to identify people who are at risk, and you need to observe those folks carefully for the development of AKI and take appropriate measures to prevent it from even happening. And so one big one is to make sure that we're closely monitoring urine output, especially in patients who are critically ill, making sure they have at least 30 cc's of urine output per hour and that those numbers aren't significantly dropping. That's really important here. And we can also look at things like serum osmolality tests. So one of the early signs of tubular damage within the kidney is the inability to concentrate urine. So if we get someone who has really kind of on urine testing, has really unconcentrated urine, so it's pretty dilute, that might be an early indicator of AKI, especially when we're not expecting that dilution. You know, we have relatively even I and O's, but we're not concentrating urine well. That could be something to really monitor for. Other things that we might see in the urine that might be that might indicate the potential for AKI are things like protein in the urine, blood in the urine, or things called casts or crystals that show up that should really not leak out into that urine itself. And we can also look at measures of serum BUN and creatinine to look at whether or not we're building up that nitrogenous waste. Some of these things, so like proteinuria, blood in the urine, BUN and creatinine elevations, these can take a couple days to develop. So really watching for these other things, serum osmolality and UO changes might be some of our bigger, ways to look for this earlier on. And then once AKI does occur, or if it does occur, then we need to really identify and correct whatever the underlying cause was. So with AKI treatment, we really need to first carefully regulate our fluids to maintain fluid volume, and we really need to closely monitor electrolyte concentrations to make sure that they are not, getting into numbers that could cause significant morbidity and mortality in our patients. You also really need to closely monitor for and prevent any secondary infections. The risk of secondary infection is extremely high in AKI patients, and that's another one of the reasons why we see such high mortality rates in these patients. They actually develop infections from other causes, and that's what ends up, causing their death. Some of the major treatments here, hemodialysis, just, kind of regular dialysis, or one of the newer treatments is something called continuous renal replacement therapy. CRRT is used more in kind of intensive care units to constantly dialyze these patients. It is much better for patients who maybe are hemodynamically unstable. And so that's really been an advantage for treating AKI, again, because sometimes if someone is hemodynamically unstable, which we often see in these critically ill patients, they don't tolerate hemodialysis very well, but they can often tolerate CRRT. So that's been a bit of a game changer for the treatment of AKI. Really kept people kind of going a little bit longer while we wait for those kidneys to sort of repair themselves. This is a standard CRRT replacement unit, and a nurse is kind of running that treatment constantly while that patient is in an intensive care setting. So we're going to move on to chronic kidney disease. We'll talk about some of the diagnosis, its causes, some of the clinical manifestations, and we'll briefly touch on treatment, although more of the treatment you'll discuss in the chronic health course coming up in a couple semesters. So some of the assessment indicators that we use to determine the extent of chronic kidney disease are here. GFR, or glomerular filtration rate, is considered the best measure of overall kidney function. We really do it by an estimate that's based on serum creatinine levels. There can be a lot of variation in normal GFR just based on like sex and weight and age and those kind of things. So we really do this kind of estimate. There's a lot of different math kind of equations that go along with it that I won't make you think about, but GFR is one of the major measurements that we use. Our little picture over here on the side shows the relationship between renal function and nephron mass. So each kidney contains about 1 million tiny little nephrons. And there's a proportional relationship that exists between the number of nephrons affected by kidney damage and the progression of the disease. And then also how that relates to glomerular filtration rate. So you can see here way up on the top, we have really still a good glomerular filtration rate, and a lot of our nephrons are still functioning. but fewer and fewer nephron functioning also causes our GFR to be significantly reduced. So that's kind of that overall relationship again between GFR and nephron function. Another key measurement that we use for CKD is something called albuminuria. This is a key marker of kidney damage. So kidney damage is what that should say, causes proteins to leak out of the kidneys and into the urine. Um, and those who are identified as high risk for CKD, and we'll talk about some of those risk factors in a minute, should be screened for microalbuminuria at least annually. So at every annual physical exam, they should give a urine sample to see if there's any albumin or proteins that's starting to leak into the urine itself. Albuminuria and GFR are the classical guideline endorsed biomarkers for the classification of CKD. So it's really protein in the urine, which indicates kidney damage, and then GFR, which indicates the extent of nephron damage that we're seeing in the kidney itself. So with chronic kidney disease, we talk about it in stages, and you can see here on the bottom, again, there's my GFR, which is my blood test, plus my urine tests looking for albumin. So again, these are really the classic kind of markers that we use to talk about CKD. So GFR is used to classify CKD into 5 stages, and this is from the National Kidney Foundation. So stage 1, our GFR is still relatively high, but we're starting to see albumin leaking into the urine. In stage 2, our GFR is starting to be a little bit lower, so 60 to 89, so below that 90 marker, and we also have albumin in the urine. At stage 3A, we have a GFR of 45 to 59, stage 3B, 30 to 44, stage 4, 15 to 29, and stage 5 is kidney failure, where we have a GFR of less than 15, or we have someone who's on dialysis. So again, early signs of damage, albumin, and then we look at staging by the amount of GFR reduction or that overall nephron damage. So some common causes of chronic renal disease. Hypertension and diabetes are the most common causes in the United States. So hypertension, diabetes right here up on top. Polycystic kidney disease is another. We'll talk about that in the next unit. Also, people with chronic obstructions of the urinary tract that are starting to cause that kind of pressure and overall destruction of nephrons. Glomerulonephritis, we'll talk about that as well in our kidney unit. Cancers, especially cancers of the kidney. Autoimmune disorders like lupus can also cause renal disease. Diseases of the heart or lungs that reduce either blood flow or oxygen to the kidneys. And then people who chronically use pain medications like NSAIDs can also develop chronic renal disease. So we're going to talk about all of these clinical manifestations of chronic renal failure. So this is kind of an overview. And then the little picture on the side, this is directly from your reading. And I think this would be a really important kind of thing to review because it really links up the different kind of pathophysiological things that are happening underneath when someone's kidneys aren't working well, and then it links them to the clinical manifestations that we're seeing. So I think that's going to be, again, a really important thing for you to review and understand. You know, what is happening in kidney disease and how does that relate to the clinical manifestations that I see in my patient. So we'll talk about accumulation of nitrogenous wastes, alterations in water, electrolyte, and acid-base balance, anemias and coagulation disorders, hypertension and alterations in cardiovascular function, GI diseases, neurological complications, problems with the skin, and also immunological disorders. So, and the extent of kind of the signs and symptoms that we see in renal failure are really determined by things like the extent of the renal function that is present, right? The more damage we have to the kidneys, the more signs and symptoms that we're going to see. Other things are coexisting disease conditions, right? If we have someone who already has maybe an underlying lung disease, those kind of shortness of breath or those respiratory complications are going to be far more evident in that patient. And then also things like the type of renal replacement therapy that the person is receiving. Again, we're not going to talk too much about dialysis, but sometimes the treatment can also exacerbate or make some of these symptoms, you know, better or worse, depending on kind of what we're doing. And the use of things like dialysis and other treatment measures, they really kind of create a whole nother set of kind of clinical manifestations and problems that we have to watch for. So we're going to start with the nitrogenous wastes. And so these are the kind of buildup or the byproducts that start to build up in the body. We talk about them kind of separately on their own, but they're also the cause of a lot of the other signs and symptoms or clinical manifestations that we see in these patients. So one is azotemia, and this is a really early sign of kidney failure. It often occurs before really any other symptoms start to manifest themselves in these patients, and it's characterized by this accumulation of nitrogenous wastes in the blood. Urea levels are also one of the first nitrogenous wastes to accumulate. Normally, they're about 20 milligrams per deciliter, but those numbers start to rise in patients who have kidney damage. They can rise to as high as 800 milligrams per deciliter in a patient with severe kidney failure. Creatinine is another one. It's a byproduct of muscle metabolism. It's usually freely filtered by the glomerulus. It is not normally reabsorbed in the renal tubules. And so we often use it as sort of an indirect measure of GFR, glomerular filtration rate. So if the glomerulus is not filtering it well, we can assume that the overall filtration of the glomeruli is reduced, again, because it's not reabsorbed. So if those numbers go up, it's not because we're bringing more of it back in, it's simply because that filtration is really poor. Uremia means literally urine in the blood. Uremia differs from azotemia. Azotemia is merely the indication of accumulation of nitrogenous waste. Uremic states include signs and symptoms of things like altered fluid, electrolyte, and acid-base balances, and alterations in some of our other regulatory functions like blood pressure control, RBC or red blood cell production, impaired synthesis of vitamin D. And there are a lot of effects of uremia on body function. So things like encephalopathy, peripheral neuropathy, pruritus. At this stage where we have uremia, virtually every organ and structure in the body is starting to be affected. It really refers to the clinical manifestations of kidney failure itself. The symptoms of uremia usually start to develop when we've got about 2/3 of the nephrons that are destroyed overall. So kind of, maybe later on, we have a lot of nephrons in general. Our kidneys can take about, I don't know, about an 80% loss in function before we start to see really significant signs and symptoms. So they do have a lot of reserve. But once we get to this point, we really start to see a lot of the kind of clinical manifestations usually associated with chronic kidney disease. Um, so again, they're kind of all listed here. We'll talk about them a little bit more. But without treatment of this kind of buildup of nitrogenous waste, either by dialysis or renal transplant, it can really lead to things like coma or death. So this really does need to be managed. So some of the disorders of water, electrolyte, and acid-base balance. So with kidney function, you remember that your kidneys really regulate that extracellular fluid volume by eliminating or conserving sodium and water. So they are really our kind of front line in that whole water balance within the body. Chronic renal failure can lead to either significant dehydration or fluid overload when we lose that kind of regulatory mechanism. Urine concentration, usually we have a early diminished ability to concentrate urine. So early symptoms of kidney damage can be things like polyuria with really isotonic um, urine as compared to plasma. So urine it should be more hypertonic, should have more solutes typically than serum. It's removing things, right? And so if it's getting close to the same tonicity as the serum, it might be kind of an early indicator of kidney damage. With sodium regulation, declining renal function really reduces our ability to regulate that sodium excretion. So normal kidneys really tolerate a lot of variations in sodium intake. And with chronic renal failure patients, they do not tolerate those variations. Um, so volume depletion and decreased GFR often occur with restricted sodium intake or excess sodium loss. Abnormal serum sodium levels are also linked to increased mortality. CKD patients often have comorbid conditions that predispose them to dysnatremias, either hyper or hyponatremias. Also, because potassium is 100% excreted by the kidneys, we do see imbalances there. So approximately 90% of potassium is lost that way in kidney failure. Nephron excretion of potassium increases as GFR decreases. So a hyperkalemia typically does not develop until GFR is severely compromised. Causes of hyperkalemia include failure to follow dietary restrictions in a patient with renal failure. Constipation can also cause hyperkalemia. Acutely becoming acidotic can cause hyperkalemia in a renal failure patient. Extensive tissue trauma, infection, or certain medications. So those are things that we really need to be careful of in renal failure patients, again, because they can cause significant hyperkalemia, which you may recall is kind of our most kind of dangerous electrolyte imbalance. The kidneys also play a big role in pH regulation. So kidneys regulate pH by eliminating those hydrogen ions and also regenerating bicarbonate, which helps to buffer any acidity in the serum. So impaired kidney function can lead to things like metabolic acidosis, especially under excessive acid loads or the excessive loss of alkali or bases, especially in a patient maybe with diarrhea. So acidosis tends to stabilize as the disease progresses because our bones actually start to help buffer that acid. But this also leads to increased bone resorption and further contributes to some of the skeletal disorders that we see in these patients, which we'll talk about. Okay, so moving on to some of the what we would call hematologic disorders that go along with renal failure. One big one is chronic anemia. This is any hemoglobin less than 13 in men and less than 12 in women. This is really the most significant hematologic alteration in chronic kidney disease. We see higher rates of anemia in African American patients and those with diabetes as they reach these advanced CKD stages. Um, the National Kidney Foundation guidelines recommend evaluating anemia for any patient who has a GFR less than 60. So even before we have really severe um, kidney function loss, we'll start to see those effects of anemia. Because again, level of 60 of a GFR is pretty early in that progression of CKD. Assessment of anemia includes measuring things like hemoglobin, hematocrit, and iron levels. The anemia that we see in CKD is due to a lot of different factors. It can be from chronic blood loss that we see in maybe patients with bleeding disorders or from dialysis. It can be caused by things like bone marrow suppression because of the uremia that's developing. It can also be and often is because of decreased red blood cell production because if you remember, the kidneys produce erythropoietin. Remember that erythropoietin in the kidney is what is being stimulated to be released when we see low oxygen levels in the blood. So low oxygen levels in the blood tell the kidneys, hey, we need more red blood cells to increase our oxygen carrying capacity. The kidneys then pump out more erythropoietin, which directly increases red blood cell production. But when kidneys start to fail, we don't have that significant production of erythropoietin, and we often start to see anemia for that reason. So again, chronic blood loss, decreased RBC production because of that loss of erythropoietin. Another big key to anemia here is also iron deficiency. So a lot of the time, a clinical manifestation that we see in our CKD patients is anorexia, nausea, and vomiting, and that can lead to reductions of anemia coming in through the diet. They also often have a lot of dietary restrictions or dietary changes that can lead to problems with iron. And they also lose blood during dialysis. And remember that we recycle a lot of the iron, but if we're losing it from the body, we can't recycle those iron stores. The effects of untreated anemia, these are probably really, familiar to you because we've talked about this already. So just go ahead and kind of review these. But the treatment here is really to either give iron to replace iron stores, or we can give synthetic erythropoietin stimulating agents. So we can give that kind of synthetically via injection to increase RBC production. Another hematological disorder that we see in CKD is coagulopathies, so bleeding disorders that can manifest themselves as things like epistaxis or nosebleeds, menorrhagia, meaning heavy periods, GI bleeding, or extensive bruising to the skin. In CKD, our platelet production is usually normal, but usually the function of them is impaired. So if we checked someone's complete blood counts, we might see normal platelet numbers, but they just wouldn't be doing what they were supposed to do as far as preventing bleeding. Coagulation function often improves with dialysis, but it never really fully normalizes. And a lot of that might be, again, caused by things like that buildup of uremia. Um, People with CKD are at increased susceptibility to thrombotic disorders. Cardiovascular issues. This is a big one with renal failure patients as well. Cardiovascular disease mortality rate in people with CKD is significantly higher than what we see in the general population. Cardiovascular disease in CKD patients is 10 to 20 times higher, even after we make age-related adjustments. So much higher rates in these patients. One big thing and reason for this is because of hypertension. Hypertension is often an early manifestation of CKD. It's got a multifactorial cause. It can be due to things like increased vascular volume, elevated peripheral vascular resistance, decreased renal vasodilator production of things like prostaglandins, and the increased production of that renin-angiotensin system activity. So these are kind of the big reasons why we see this sort of difficult to treat hypertension in CKD patients. So early identification and aggressive treatment of hypertension is very important because it can slow the overall progression of that renal impairment. So CKD causes hypertension, but hypertension leads to further progression of CKD itself. So they are both kind of like causes and problems, right? So again, this hypertension that we commonly see in CKD needs to be aggressively treated because when that starts to happen, it really causes a lot of further damage to the kidneys themselves. So things like lifestyle changes, so increasing exercise, reducing salt and water intake, aggressive antihypertensive medications. These are things that are very important with these patients, and many of them require multiple antihypertensive drugs to get really good control. Heart disease is something that develops in these patients very frequently. So cardiovascular disease spectrum in CKD includes things like left ventricular hypertrophy and ischemic heart disease. They have increased prevalence of left ventricular dysfunction, so heart failure. Um, and this is because of things like excess extracellular fluid. The treatments that we use, like dialysis, can also further exacerbate this, and also because of that underlying anemia. Um, that can also lead to left ventricular hypertrophy. The hypertension we see in CKD increases the workload of the heart itself, and that's what's causing a lot of this hypertrophy that leads to heart failure. And that often leads to pulmonary edema in later stages of congestive heart failure. So patients might start to develop things like shortness of breath and respiratory issues. Coexisting conditions also contribute to this. Remember, we said that hypertension and diabetes are some of the main causes of kidney disease, and they're also some of the main causes of heart disease. So if all of these things are happening kind of as comorbidities or at the same time in our patients, that's going to further exacerbate the development of heart disease. And another common cardiovascular thing that we see in these patients is something called pericarditis. It is common in many individuals with stage 5 or some of those later stages of CKD because we get that buildup of uremia in those patients. So pericarditis is inflammation of the pericardium, and this is the pericardium kind of right here on the outer layer of the heart. And this is pericarditis where you see that inflammation. So if uremia starts to happen, that is what's causing that inflammation of that pericardium itself. Um, so it can lead to something called cardiac tamponade, which we'll talk about later in our cardiovascular unit. But these patients often come in with kind of this really significant chest pain, with shortness of breath, respiratory problems. Um, Fever is pretty common. And so if we see those things, especially in dialysis patients, we do have to think about the potential of something called pericarditis. Skeletal disorders are often also very common. So one big thing that is leading to this are calcium and phosphorus metabolic changes. These changes occur really early in the progression of CKD. Remember also, just like potassium, phosphate levels require daily urinary excretion to make sure we're maintaining intake and output. The kidneys are essential to removing phosphate excess from the body that we might have taken in through our diet. So when we have impaired phosphate excretion, it can lead to elevated serum phosphate levels. Decreased serum calcium levels stimulate parathyroid hormone release, causing calcium to be reabsorbed from the bone. And remember, as phosphate levels increase, we get a resultant decrease in calcium levels. And so that's why we have decreased serum calcium levels, but your body responds to that by breaking down bone so that we can bring up those serum levels. So that's really kind of that cascade of things is what is leading to a lot of these skeletal disorders in patients with CKD. Increased PTH function maintains that serum calcium, but it also does it at the expense of our overall skeletal health. We also see vitamin D synthesis problems in patients with CKD. That's impaired in CKD patients. The kidneys are responsible for converting inactive vitamin D to calcitriol, and that's its active form, what really helps to increase calcium levels. So reduced calcitriol levels lead to elevated PTH and also impaired intestinal calcium absorption overall. Vitamin D really regulates osteoblast differentiation, and that affects bone replacement. So again, that CKD or that kidney involvement in vitamin D synthesis exacerbates the skeletal disorders that we see. We can also get secondary hyperparathyroidism. This develops in most CKD patients because of the downregulation of parathyroid receptors. Elevated PTH levels often are the result of decreased vitamin D and calcium receptor activity. PTH and vitamin D mobilize calcium and phosphate to maintain those serum levels, further leading to more bone breakdown. So skeletal disorders really are the underlying cause is this kind of overall abnormal reabsorption and defective remodeling of bone. There are multiple causes, there are multiple ways that we talk about this in the body, but regardless of the cause, it manifests itself in our patients as this kind of overall bone tenderness and muscle weakness. They also tend to develop more bone fractures. They have osteopenias and osteoporosis, and they really need early treatment. And the main early treatment here is to treat that hyperphosphatemia that leads to these big changes in calcium levels. So we have to treat hyperphosphatemia, whether it's lowering the absorption of phosphorus in the body, or treating the hypocalcemia that results to prevent these overall skeletal complications. We also see altered drug metabolism in kidney disease. I'm sure you've talked about this quite a bit in your pharmacology class. CKD and its treatment can interfere with the absorption, distribution, and elimination of drugs. So altered drug absorption is often caused by antacid treatment. We use antacid treatment to reduce the amount of phosphorus that's being absorbed in the body. Remember that calcium will bind to phosphorus and keep it from being absorbed. And so these patients often take antacids. But those antacids can also interfere with the absorption of other medications these patients are taking. So that's one issue with drug metabolism in these patients. We also see altered metabolism of drugs. We see less protein-bound drug in the body. So remembering that when drugs are bound to proteins, they're inactive. So if we see less protein binding, we have more active drug, and so patients with renal disease may have to have dosages reduced to prevent toxicity from different drugs. And we also see increased intermediates of different drug metabolisms that, again, may require a reduction in overall dosage for these patients. Okay. Other disorders that we see in patients with chronic kidney disease, and the majority of these can really be explained by, again, that uremia or that buildup of waste products in the blood that we get in kidney disease. So there are a lot of GI complications. Anorexia, nausea, and vomiting are common. They can also develop ulcerations and bleeding in the GI tract. Hiccups are really common. In the neuromuscular system, we see neuropathies and encephalopathy. We see gait disturbances, this kind of abnormal or ataxic sort of movement. We see a decrease in immune response, so they're more susceptible to infection. Skin can become dry and pale from things like anemia. These patients often experience this kind of intense itching, again, from the uremia buildup in the skin itself. And so we worry about skin integrity in these patients. They do a lot of kind of like severe or aggressive scratching because of that intense itching that can cause damage to the skin. They're already at risk of immune response, so we really do need to be cautious there. And they also commonly develop sexual dysfunction or impotence in our patients. We also see sexual dysfunction or severe loss of libido in our female CKD patients as well. So treatment of renal insufficiency stage of renal failure. So this is where before we see significant renal function loss, we want to start treating this really early. So we want to use measures that slow the deterioration of renal function and really start to assist the body in managing the effects of that impaired function. So we need to aggressively treat any urinary tract infections promptly. We need to avoid administering any medications that could potentially damage the kidneys. We need to aggressively keep their blood pressure under control. We need to aggressively keep blood sugar under control in patients with diabetes. And any patient with renal impairment who smokes needs to stop doing so. So target populations with compromised renal function that we should watch or that we may treat are patients with that chronic renal insufficiency that we would be taking care of those measures we just talked about. But we also may be caring for patients with renal failure who are on hemodialysis, who are on peritoneal dialysis, or who have received renal transplants. So dialysis is one of our mainstays of medical management for patients with renal failure. We can do it two ways, either hemodialysis or peritoneal. We're going to talk about this really at length in your chronic health course. So I'm just going to kind of mention them here, and then we'll pick that conversation up in subsequent semesters. Same thing with some of the other treatments. So things like dietary management. We may reduce protein in those advanced stages because protein breakdown in the body is really the main way that we produce those nitrogenous wastes. And so we would need to meet their energy needs with things like carbohydrates and fats. So you're increasing carbohydrates and fats to increase calories while reducing overall protein intake. We also need to carefully monitor sodium and water intake. But that is really something that is monitored like on a person-to-person basis. There can be a lot of variation in how these patients react to different levels of sodium and water. So that's a really individualized kind of thing that we look at with renal impairment patients. But with potassium, we often put these patients on significant potassium restrictions and also significant phosphorus restrictions to prevent the accumulation of those two electrolytes in these patients. We can see chronic kidney disease in children. It's often caused by things like congenital malformations anywhere within the renal system and even into the urinary system. They can also have inherited disorders that are affecting their kidneys. They can develop acquired diseases that affect the kidneys and also metabolic syndromes. Some of the big things that I'll say about children, though, is we really need to manage CKD somewhat aggressively in children because it can severely impair their growth. It can cause significant developmental delays. It can delay their sexual maturation. Because of its effect on bone health, that can be very significant with bone abnormalities in children during that time of sped up growth. And it can also cause them to develop a lot of kind of psychosocial problems, especially because of the sort of chronic illness factor that we see in CKD in this population. And with elderly patients, there is an overall normal decrease of GFR with age. And that's what we talk about when we talk about that kind of renal reserve with aging. So this kind of increased or this sort of overall decrease in GFR over the years. So these patients have increased detrimental effects of nephrotoxic drugs. So even if someone doesn't have like a diagnosis even of CKD, older patients really need to be any nephrotoxic drug needs to be used with extreme caution in older patients. They also have greater incidence of kind of those sort of causative factors of kidney damage. Things like cerebrovascular, cardiovascular, and skeletal system effects are also far greater in patients who develop CKD at older ages.